Bom dia a todos, estamos aqui para mais uma reunião semanal de disciplina de Urologia. Hoje uma reunião especial. Nós temos aqui o professor QUOC-DIEN, sorry QUOC, about the pronunciation, da Universidade Johns Hopkins, que vai participar apresentando um tema muito interessante. E a reunião hoje será coordenada pelo professor Leonardo Oliveira Reis. Leonardo.
Bom dia a todos. Thank you so much. QUOC is an associate professor of surgery at Harvard Medical School. And thank you so much for your time, for joining us in this meeting. We will have about 2 cases in the first 30 minutes of the meeting, and then we will hear your talk about focal treatment of prostate cancer in 2021. So, Matheus, please share your screen and show the cases.
Beleza. Então, inicialmente, eu apresento aqui as 2 páginas da disciplina, que são a nossa página do Instagram e do YouTube. Recomendo fortemente a todos que não sigam essas páginas a seguirem, para ficar mais por dentro aí das nossas atividades, nossas principais atividades. Conforme o nosso convidado internacional, nós vamos fazer a apresentação de casos e discussão toda em inglês. All right, for the first case, we have MCV, 63 years old, a patient that comes for prostate cancer screening. The history of past illness, just for time localization, this is 2012, and he comes for prostate routine, as he said. He had a PSA elevation for 346 and a negative prostate biopsy 1 year ago in 2011. For the past medical history, he had no comorbidities and no smoking history, and no sexual or avoiding dysfunction, as he said. So we proceed with the physical examination. Had a blood pressure of 140 for 80, cardiac frequency of 80, and the rectal examination, the prostate was something like 30 cubical centimeters with a fibroelastic and no nodulations. The laboratory exams, he had an hemoglobin of 13, a creatinine of 1, and a PSA of 565. This is 2012. This is the PSA that he came with. For imaging, he had a prostate ultrasound that had no post-voiding residue, and a prostate of 25 cubical centimeters. What to do next? You want to discuss?
At the time, yes, we can go ahead, but usually we would order MRI before anything here. QUOC, do you agree, QUOC? Would you start by an MRI, or would you do anything different?
Yeah, I mean, this is I don't know what you guys did back in 2012. I don't think this was common practice back then, right? But today, yes, I think, with the New England trial that really showed an increased yield of significant cancer if you do an MRI pre-biopsy, it is definitely worthwhile, and especially in somebody who already had a negative biopsy, it's even more worthwhile. But even interestingly, you would think, oh yeah, it's the US, everybody has resources, they're doing MRIs, everyone. But I would say the community practice in the United States, it's probably still more than 50% do not do an MRI for all sorts of reasons. They'll do a biopsy, and then if it keeps rising, they'll do another biopsy. I think people are finally starting to change, but it's not, I wouldn't say it's absolutely standard of care practice in my country yet.
Great. So also, you can avoid unnecessary biopsies also with MRI. if you have a negative MRI and low PSA density, you can feel comfortable to avoid unnecessary biopsies.
Yes, I think in our practice, my practice, definitely I feel comfortable doing that. But interestingly, I think maybe it's how we practice medicine in the US, but you know, I think the majority of people, if you do an MRI and the MRI is negative, they're still going to do random biopsy. And the thought process, maybe part of it is medical, you know, is legal. You know, the current guidelines say that if you have an elevated PSA, you're supposed to do a biopsy. And then there's an option for a pre-biopsy MRI. So they don't say do MRI if MRI negative, don't do biopsy, at least not for now in the US.
Okay. So go ahead, please, Matheus.
Right. So we checked a new PSA back then, and it was 619, 3 months later from that first moment. And he had it was asked an MRI, and it was no there was no back in then. There was no periods classification for that back in 2012. So it was something that was just asked. He was submitted to a new biopsy.
Yes. Any different here, QUOC, for the new biopsy? Now is okay, but which kind of biopsy? How many cores or standard?
Yeah, before I even I said I was going to ask what kind of MRI. You know, back then I'm not even sure I remember what was the standard. Was it multi-parametric, or I assume it was 1.5 Tesla back then, right, in 2012 or 13.
With the intrarectal coil.
Yeah. Okay.
That was that.
You know, it's interesting because I don't know if you've when you look at the films, it's crazy how in my opinion, how things have changed, right? The you know, sometimes it's like a black box, especially us urologists, because we don't, you know, routinely necessarily read MRIs. But you just pull up pictures of old MRIs done around those years, you can barely see anything. You know, it's just a big pixelated map. So MRIs change a lot, and you know, you wonder if you did the MRI, would you have seen lesions? You know, with the current standard of 3 Tesla and multi-parametric MRIs. In terms of, I think you asked me, Leo, about approach, right?
Yes.
Yeah, I'm curious to hear what you do in Brazil. You know, in our practice here, as we know, Europe has moved, Europe, Australia, a lot of countries have moved mostly towards transperineal biopsies, right? In the US, the vast majority are still rectal. Interestingly, we just started adopting transperineal biopsies. We're not yet like offering 100% transperineal. If anything, we just started. But adoption of transperineal biopsy has been extremely slow in the US for a bunch of different reasons. But you know, I would assume that a couple of years from now, 2-3 years from now, we'll get there. So curious to know what in Brazil you guys do right now.
Well, yeah, maybe we will do 12 cores, a standard biopsy again. You would do the same, maybe, okay?
Yeah, I'm just saying that transperineal, right?
Okay.
I don't know if you guys are, yeah.
No, we do standard 12 cores.
Okay.
Matheus, go ahead, please.
So that was done, 12 cores. It was found in adenocarcinoma, Gleason 3+3, in 2 of 12 fragments, affected for 15 to 20% of each one. And the anatomical place was the middle left gland. It was affected.
Okay, so it's a unilateral disease on biopsy, two cores of 12, 15 and 20%, and then go ahead. So what would we do? So go ahead, Matheus.
So this is the question that we have right now.
This patient can get pretty everything you show in your screen. So even radical prostatectomy, radiotherapy. But talking about less invasive, minimally invasive, or just surveillance, what would be the difference here? If you consider focal therapy, would you do cryo or HIFU QUOC?
I personally, so, like, as I'll show in my talk, I'm definitely not a focal therapy everything person. As you know, I do a lot of radical prostatectomies. That's what I do most in my practice. I do perform some focal therapy as part of clinical trial, and now also outside of clinical trial. To answer the question about the energy source, I can't tell you that I have a strong preference for one energy source over another. For me, it's the concept of focal therapy to treat an area rather than to treat the whole gland to minimize side effects and hopefully, quote unquote, preserve good oncological outcomes. But then should you be using HIFU or cryoablation? I think it's more a matter of personal preference, because both have sufficient data to suggest that at least from a biological standpoint, it does what it's supposed to do, which is destroy tissue, and also in a precise manner. I tell you, in the US, it's interesting because the way we practice is cryotherapy was extremely popular in the early 2000s. And then a lot of people did cryotherapy in not necessarily the most standard of care fashion, a little bit, basically cryotherapy for all indications, low risk, high risk, intermediate risk. And then the outcomes, as you can imagine, were not so great, and a lot of recurrences. And it's as if cryotherapy has fallen out of favor in the US. A lot of patients, if you start talking about cryotherapy, they're going to be like, what? This is archaic. This is old technology. I want the latest and greatest. I want HIFU. I want laser. But in my opinion, they're just different energy sources. I tell you, it's hard sell to do cryotherapy in the US. So HIFU is what we tend to do here at my institution. But in terms of this specific patient, like I said, I'm not a focal therapy extreme enthusiast. I'm not somebody focal therapy for everyone. I think this patient has very low risk prostate cancer, at least for now. And the outcomes, as we know from the PROTECT trial and other data, is that the outcomes would be same regardless if you do surgery or radiation or do nothing. So I don't see necessarily an indication for focal therapy here, and I would probably push this patient towards surveillance. For me, somebody that wants to consider focal therapy is somebody who has unilateral disease in one specific area, ideally targeted, that shows up on MRI with significant disease. Let's say Gleason 7 disease would be a good candidate. So this patient, I would favor surveillance. If he absolutely wanted definitive therapy, there are options out there. I'm not sure I would recommend focal therapy for this patient.
Great. So you know that still many patients like this go for radical prostatectomy, considering the anxiety that the disease brings. So maybe focal therapy might be a way of rescuing such patients of undergoing like more radical treatments. Do you agree? For those that are very anxious and need treatment, and they decide, no, doctor, I need a treatment. So then let's do something like focal compared to more radical treatment for you if you really want something. Do you agree?
Yeah, so I agree with you, but at the same time, I would like to point out, when you say the patient is too anxious, as a physician, it's your role to explain the evidence in words that the patient can understand and negotiate with him, have this dialogue about why surveillance is a good option for somebody like him. And I can tell you in my personal experience, there's a lot of patients who come to Dana-Farber because, as you know, I'm at Brigham and Dana-Farber, it's so complicated, but I see most of my cancer patients at the Farber. And they come for second opinion and they're all ready to sign up for surgery. But then you explain to them the evidence, you explain to them the PROTECT trial, you basically negotiate with them, and then they come to the conclusion that surveillance makes sense for them. And the last thing I'll say and emphasize is, Leo, you may agree in your practice too, is that when the patient who most regret their treatment are this kind of patient, somebody with Gleason 9 prostate cancer that I saved his life because I removed this cancer, and he's impotent. Well, you know, such is life, but I saved his life. But the Gleason 6 individual here, if he is not preserving his erection, he's really not happy, and then reads a lot about it, and then goes on the internet, and then comes back and says, you know, that everybody says I should not have been treated. You know, why did you push me? I didn't push you. But, you know, I think it's important to have that dialogue. Otherwise, the patient will be unhappy. And I don't know what's your experience, but I can definitely say
it's similar. Yeah, that's very important. That's why I bring the discussion to this kind of aspect.
You know, as you know, Leo, I'm doing business school right now, and one of the things that one of our professors was saying is that, and this is a person who's a hostage negotiator, somebody who this was his previous life, you know, for working for police and negotiating with hostage takers, and he said that what he's noticed is that one of the people who are sometimes the best negotiators are doctors, because this is all they do. We offer surgical treatment, but the part that is before the surgical treatment is basically an exercise of negotiation or under duress. So that's an interesting thought. Yeah.
Yes. So let's go ahead, Matheus.
So this was done. We talked with the patient, discussed every option of treatment. He did not like the active surveillance because he was very anxious about the disease. But when we talked about radical prostatectomy and radiotherapy, the patient was, whoa, this seems too much. Is there another option? And then cryoablation was in the beginning, as Professor QUOC just said, and he said, I'd like to try that. Even though there's a lack of medical evidence for that, I'd like to try that because that's new. And it was done. Amy Gland left cryoablation. Here just an image to represent the procedure. We have a probe, rectal probe to guide the places where we're gonna put where we're gonna make the procedure over there.
So Matheus, let's just show the case, finish this case, and we go to the next case. Yes, show all the case, just keep presenting, show what happened, and then we can move to the next case.
Right. So after the procedure, the patient had no sexual and no void dysfunction. The follow-up after 45 days after the procedure, the PSA went to 0.67, and it was 10% of what was in the beginning. Here we have the PSA follow-up.
Matheus, just a sec, go back a second. This is something that we can discuss in the next case. So here, after an ME ablation, the PSA decreased 90%, means just 10% of the previous PSA. And then we can discuss in the next case how this might be important. And then you made an ME ablation, but the PSA went down 90%. That might be something. Go ahead, please, Matheus.
All right, here we have the PSA follow-up. Here we have the procedure was done in late 2013. And here we have the beginning of the PSA. It was 0.67 and went down to something near 1. And it kept coming up until November 18th. In November 18th, the PSA was 3. He had a negative MRI, and a new biopsy with no malignancy findings was done because of the Phoenix protocol. It was 2 points greater than the nadir. And here we keep on following this patient, and the PSA always been between 2.5 and 3. So here, 2021, the PSA is 2.6. Is a 71 years old patient with no sexual or voiding dysfunction, and keeps the question on how to follow the patient. Today we have a great MRI, we have biopsies, what we could do. Just to represent it, I had a paper here of the late 2020 that says about this. This is a clinically significant prostate cancer, not this patient's classification of cancer, but here they talk about the MRI and how important it is to guide biopsy in these patients, and this could be a follow-up. This is and I have follow-up. All right.
Good. Go back. Yes. When you go to move to the next case, please, Matheus. Please let's go to the next case. So in the meantime, QUOC, do you have a clue which would be the PSA trigger for a new biopsy if everything is okay, like a digital rectal examination, okay, everything okay, MRI negative, but the PSA goes up like 2 unities, like the Phoenix criteria? Would you use this for a biopsy trigger?
Yeah, my conversation, I mean, everybody has a different view of this. As you can imagine, it's really opinion. And one of the things I will actually talk about in my lecture is how heterogeneous people do whatever they want, right? Some people use the Phoenix criteria. Some people do biopsies every year. Some people do MRIs every year. Some people do none of this. So it's quite variable. And I'd say, you know, in our practice with HIFU, we have been extremely conservative, meaning that we tend to repeat, like we consider them like active surveillance, right? And also most of the patients that we do in HIFU is patients that have a lesion, and then we target that area, but we're leaving behind some Gleason 6, you know, here and there. So we just continue with the surveillance protocol. And if you ask me what's our surveillance protocol, is PSAs every 3 to 6 months, depending on kinetics, and then a biopsy with MRI before the biopsy every 2 years or so, right? That's our surveillance protocol. So we tend to do something similar for focal therapy patients, but then obviously we have to emphasize, you know, if the guy's 77 years old, we're gonna, you know, loosen up on the protocol and maybe just do imaging. So it'd be something like that. This patient who had cryo, I would probably have repeated imaging every couple of years and maybe repeat a biopsy every couple of years as well. And in addition, use triggers of PSA to say we need to move things forward. Yep.
Yeah, we do about the same, yes. So Matheus, we have another 10 minutes for this case.
All right, here we have IBS, 69 years old, and he came with a PSA elevation. He had no symptoms, no voiding dysfunction, no sexual dysfunction. He's an active engineer, and he came for a prostate routine, as he said. He has hypertension and diabetes and no history of smoking or occupational diseases. He denies history family of prostate cancer. And in the rectal examination, the prostate was a bit greater than the last one, with no lesions, it's fibroelastic with no nodulations. The laboratory exams, he had a normal exam except for a PSA that is 561, and it was confirmed with a new PSA in 1 month of 555.
Yeah, go ahead.
He had an MRI with a prostate volume of 45, and there was a PIHADS 2 over here. The patient was submitted to a prostate biopsy that came with an adenocarcinoma Gleason 3+3 in 2 of 12 fragments of the middle right third. It was an Isaac 1. With an estimated 30 or 40% of affection on each fragment.
So a question here: what are if you have your quality control aspects or for the biopsy? Are you like monitoring if we have at least a 10 millimeter per core or 12, or what do you usually do to check if your biopsy have enough quality?
I'd say that's a good question. I don't think we have, like, seriously, just spontaneously, I'm not sure that we have that quality control. I don't think that we measure necessarily our fragments. We did, like I can tell you as the clinical director of my division of urology, we did change biopsy gun because we felt the cores were not of great quality, but it was more qualitative than I never actually took a ruler and measured the fragments of the samples. But your discussion does raise an interesting thing. Is that do you do in-bore biopsies in Brazil, like in-bore under direct MRI guidance?
No.
Okay. So we have, before we even did fusion biopsies, our radiologists here were able to do in-bore biopsy. So in-bore biopsy is real-time MRI, and then they stick a needle. So as you can imagine, it can't be the regular metal needles because these are in the MRI cycling. So they use these special needles, and they're tiny. And that I have to admit is a concern of ours, because we have a lot of cases where their samples are so small, and then you're like, it's 80% of the fragment cancer, but you can't compare to the regular cores that we take from a regular biopsy.
What we do is you should have cores that are beyond 12 millimeters that to be considered a core. If you say like 2 and 12 means 12, at least 12 millimeter also extension. I mean, in terms of the core size. We used to say 10 millimeters, but we have studied this a little bit and found that 10 is still not a good enough core. But this is still open in the literature, and there's still a gap in our practice, because sometimes you say you just read the what you get as a conclusion, and you don't care about how much quality you have there.
I don't know if you would practice something like that where you are, but the other good thing in terms of quality control is that only 3 of us do targeted biopsies. So even though we are 16 urologists, only 3, everything is centralized to 3 of us, me and 2 other people who do all the biopsies.
Yeah, that helps a lot. But when you go for a private practice and to the real world, it depends on who is going to pay for the patient, and then you get lots of different places.
Leo, I have a question to Professor Cole.
Yeah,
Professor Cole, in this case, the MRI is negative, it's period 2, and Leo still perform a biopsy. In your practice, if you have a MRI 1 and 2, you will still perform a biopsy, because what is the sense to perform a MRI? We do a biopsy in everyone. So
I agree with you, and I tend to try to negotiate with the patient about not doing it. But we have our guidelines in the US, right? And the guidelines don't mention, depending on the MRI result, do or not do the biopsy. So I usually inform it. I'll give you an example. Let's say the patient has a gigantic prostate. He's not the youngest or fittest person, and the MRI is negative. I think all of us agree that we should be comfortable saying we don't need to do a biopsy for this individual. But my discussion or my negotiation with him will still be saying, well, sir, your density is not concerning. Your MRI is completely normal except showing a big prostate, but the current guidelines recommend still doing a biopsy. I personally think that we can safely avoid doing the biopsy, but it's still your choice because these are the current guidelines. Yeah.
What a percentage of false negative?
That's a good question. I mean, I think that in the literature, depending on who you read, if you read Hashemet's paper in Lancet Oncology, the defined as Gleason 4+3, you would only miss about 4% or 5%. They did these saturation biopsies in their studies. But if you loosen up the definition to Gleason 3+4 of any sort, then it's more like 85% accurate. So you would miss about 15% of Gleason 3+4s or higher. And then you could argue that, well, those 3+4s, we could probably pick them up next year as long as you track them carefully. So I don't think you miss much. And I don't know, in your experience, my experience, I have not seen much situations where we decide not to do the MRI, and then next year after we do a biopsy and oh my God, it's Gleason 9. We never see that, and I've never really seen something like that.
Okay.
So let's show this case because this is a little bit different from the previous one. And go ahead, please, Matheus.
Well, actually, for the management, it was the same thing of the other patient. He was submitted to a cryoablation, same as the other. But in the follow-up, 45 days after the procedure, the PSA went to 244. It was something like 50% of the previous PSA. Had no sacral or no vortex dysfunction.
Yeah, just a quick point here. From here is something weird, but still, let's follow the game. Or would you do anything different here?
I don't know how much you rely on those parameters, but you have to. I mean, I don't know what your thoughts are, but I can't say I rely that much on these numbers because like part of it is like if you still have inflammation. Your PSA goes down because cells are killed, but then your PSA is a little higher because it's still recovering from the procedure. So I don't know how much to make, out of these numbers.
Yeah, go ahead, please, Matheus.
All right, so here we have the follow-up of the PSA of this patient. The procedure was done in late 2013, and here we have the PSA became stable till July 2016. And it went a little up. Here in March 2007, the patient, we requested another biopsy for this patient that is here. The rectal examination, the prostate was indurated in the left middle. The PSA was 545, and a new biopsy was ordered. But the patient lost a little time over there. And he came November 2017 with a PSA 969. With the rectal examination, the prostate was the same. And with another MRI, with a pH 4 in the left side of the gland, it was a lesion of 1.5 centimeters. No extraprostatic invasion over there. And he came with the biopsy with a prostate adenocarcinoma Gleason 3+3 with fragments affected in the left right now, middle third, 2 of 12 fragments, 50 and 30%. Here, remember that previous right he was submitted to a previous right hemiacral ablation.
Would you offer to complete and do the ablation to the side where?
I don't like his PSA kinetics. So I would say that makes me a little concerned about that. Obviously, I'm not surprised that there's cancer on the contralateral side. One of the things I'll say in my little presentation next is that 90% of 80 to 90% of prostate cancer are bilateral. So it's not a surprise to anyone. I guess this was not. You didn't do a targeted biopsy here, right?
Yes.
Yes. This was random or targeted?
No. This was a cognitive biopsy. Okay. We had the MRI, and after that we have the biopsy over there.
So personally, interestingly, I have a case that is a little similar as part of my presentation that is HIFU. But the short of it is I am highly uncomfortable about his PSA kinetics. So I'm not sure I would go and plus the whole point of doing focal therapy is to avoid side effects. And if you're ablating the other side, you end up having quite similar side effects to, radiation or surgery. So why bother with this kind of thing? But again, I just want to emphasize, I'm like in the middle. I'm not against focal therapy, but I'm not also one of the people who think that focal therapy is the solution for everything. In this case, I'd be a little...
Great. So we fully agree with you. So that's why we directed this patient for a radical prostatectomy. So go ahead, Matheus. Considering the PSA kinetics, we recommended radical prostatectomy.
Mm-hmm. Wow. Okay.
Yeah. It was an eventful surgery with a difficult dissection in the right third, mainly in the apex. The anatopathological findings was the adenocarcinoma Gleason 3+4, NICEP2, affecting both lobes, as it was said. There was extra prosthetic extension in the time, and the urethral, and there was urethral and vesicle margins affected. The seminal vesicles were affected too. It was a PT3B.
Yeah, you know, this is interesting. I obviously this is a case that makes focal therapy look really bad. But you know, I don't know if any of you have met my chair, my chief, Adam Keibel, and you know, we have similar practices. We are also open and interested in focal therapy. But I mean, I don't know if you would agree, but there's also some bias of the cases we present. I'm going to show you a case that's even more dramatic than this one. But it seems like any bad outcome of focal therapy ends up at tumor board, right? Or these kinds of lectures. But then, you know, there are people out there who got focal therapy who are doing totally fine. But yes, this is a dramatic case that makes us, you know, wonder if this is an appropriate treatment or not. So,
go ahead, Matheus.
Yeah, despite of that, the biopsy over there that we read, the patient was not submitted to another adjuvant therapies like radiotherapy. The PSA went to 0 and is still 0 today.
So surprisingly, he got cancer control despite of positive margin and locally extensive disease. Mm-hmm. So maybe this patient would get adjuvant therapy, but it's hard to say how he is still controlled with 0 PSA, considering the pathological report. So this would be a standard adjuvant therapy or a straight adjuvant therapy based on the pathological report, or would you consider just follow the PSA post-surgery?
Yeah, our paradigms have shifted in the last few years, you know, with all the studies that have come out recently suggesting that salvage treatment is, you know, has the same outcome as adjuvant for anybody with adverse features. Obviously, this patient is at extremely high risk, and I want to make sure that I follow this patient correctly. I'm sure in your practice you have the same problems, right? I don't think that I have caused much harm in favoring the observation approach and salvage as needed. Mm-hmm. But once in a while, like as recently as yesterday, a patient was lost to follow-up for 2 years, right? He had PT3B disease, lost to follow-up, then reappeared, you know, COVID and all that stuff. And then he reappears and his PSA is now 1, you know, or like, you know, 0.90 something. So, and that patient, we're going to give salvage treatment, but I think it may be too late. So I think I would definitely favor this, you know, observation approach, but I would emphasize that this patient cannot, you know, we don't want to lose this person to follow-up.
Great. So we can finish Matheus and then we go to the Professor QUOC presentation. So for those that joined later, we have the honor to hear today Professor QUOC-DIEN, that is Associate Professor of Harvard Medical School. And we're going to talk about focal therapy in prostate cancer. Where are we in 2021? Professor QUOC, please, you have the...
Perfect. And you see my slides, right?
Yes.
Okay. Right. So I'm going to, as we talk, I mean, a lot of the talking points that I want to make, I already mentioned it as part of our case discussion, which was, by the way, extremely interesting. And thank you for having me. You know, let's go over this presentation, and I have a case that is quite interesting and a little similar to what you showed earlier, Matheus. So what is the role of HIFU focal therapy in 2021? These are my current disclosures. And I like to do this now where I put my presentation slide to my conclusion slide to start. And the idea is that focal therapy is definitely an option now for patients who are trying to minimize morbidity from the treatment and potentially to have the same or good oncological outcomes. However, it's important to understand that there's such heterogeneity in how studies are designed, how treatments are administered, and importantly, follow-ups, right? And how do we determine recurrence, as was pointed out earlier. And we will see in the upcoming years the trials that are going to come out, but also you know, in the US, the financial side is quite important. I'll give you some anecdotes about that side of things, okay? So as we know, you have seen this before. This is the curve of innovation adoption. And we tend to often say that in medicine, things proceed more slowly compared to the world of tech. This makes complete sense because we are doctors. The errors that we can make have serious consequences for patients. If you make an iPhone and the iPhone is not great, well, you throw it to the trash can, not much consequence. You may be unhappy about it. But for patients, there are serious consequences. So that's why adoption of technology is a little bit more complicated in medicine. And it's also important in medicine that we make the difference and the distinction between something that is on one side a revolution, which I guess you could qualify something like immunotherapy, right? I think we agree on that. Nobel Prize winning, actually from Dana-Farber last year. And on the other side, you have things like Theranos, right? You know, this whole idea that you could do a blood test with just a drop of blood. In the end, it came out basically a scam. It doesn't work. You can't do that. And then, to be honest, most things in medicine are in between, and they are evolutions. And I think, and some of you will completely disagree still, but I think that robotic surgery was an evolution. It did do certain things better, but it's not like the solution to all our problems. So in that context, all adoption of technology in medicine is reflected under a lot of scrutiny. And we're talking about scrutiny from legislators, you know, so a lot of regulations, a lot of rules that are changing, and also scrutiny from key opinion leaders. And I think I find it quite fascinating, and you know, some of us may laugh about it, but the people who pushed, I would say, robotic surgery in the early 2000s, who were at that moment the innovators, the people who were trying to change the world, whereas everybody was saying this is a scam, stop doing robotic surgery, this is not better. Interestingly, a lot of those people are now on the other side. They are the people who are scrutinizing focal therapy, who are saying, hey, this is a scam, we shouldn't be allowed to do these things on our patients, that, you know, we need to stick to the standard of care. So I do find it interesting if you follow the history of our field and how things have changed over time. So what is focal therapy? Focal therapy, by definition, is the targeted focal destruction of cancer tissue, and then you're trying to preserve everything around it. The idea or the key performance indicator is that you treat the cancer successfully, but with less side effects. And interestingly, the concept of focal therapy, when you think about it, is adopted in so many other cancers, and that includes kidney cancer, right? Or breast cancer. When you have cancers in those organs, the plan A ideally is only to treat the tumor that is visible and leaving the rest of the tissue behind. However, there are caveats for that in prostate cancer, and let's talk about it right now. Focal therapy has also changed over time. You know, what constitutes focal therapy? You know, the old school focal therapy or cryotherapy is almost like a hockey stick ablation, where you will hemi-ablate, you know, the side where the cancer was, the significant cancer was detected, and even more, and potentially ablating everything anterior on the other side, and just really leaving the neurovascular bundle and the tissue around it on the other side. So, you know, some people may have called it focal therapy back in the day, but it's actually a 3/4 ablation when you think about it. And then at some point, the field moved on to something more like a hemiablation, you know, treating the side where the significant cancer was found. And then ideally, or at least people are thinking about it, now that we have such great technology in MRIs, we're going to talk about true focal therapy, where you only ablate the lesion that is seen on MRI where the biopsies were positive, and you leave everything else alone, including tissue on the same side of the tumor. However, if you are a proponent of focal therapy and you believe in focal therapy, you have to believe that, you know, prostate, you know, the ideal scenario is what you see on the top, which is that you have an index lesion and you have no cancer anywhere else. However, that's just not simply the case for prostate cancer. There are cases like that. And once in a blue moon, when you remove a prostate, you'll see somebody with cancer in one dominant lesion, no cancer anywhere else. But it's a minority of cases. The majority of cases end up being in a scenario like B, where you have an index lesion where it is bigger and seen on imaging, but you do have specks of cancer cells everywhere else. And that's the real question. Can you treat this person and be successful so that those secondary lesions do not cause significant harm? And then if you have a scenario like scenario C, then probably these cases are not great candidates for focal therapy, because in the end, you treat the wrong indite lesion, and then, or you treat a couple of lesions, but you leave some of them behind, and then you're not going to have a good oncological outcome. And if you treat all the lesions, you end up treating the whole gland, and then what's the point, right? You might as well do standard of care definitive therapy that's out there. One point that I like to mention that we talked about in the cases earlier is that focal therapy ultimately will only be as good as our ability to detect significant cancer, right? So, you know, those cases were interesting because some of them went back as far as 2012. And we do know that, you know, MRIs have improved drastically. They've improved from a technical standpoint with, you know, the endocoil, but also 3 Tesla multiparametric. And they have improved from a reading standpoint. Radiologists are increasingly getting better to be able to read these tests. I don't know if you've looked at inter-observer variation or even intra-observer variation, but there's a lot of heterogeneity there that the more we have better quality control, the best we'll be able to do focal therapy, I would think. And, you know, more interestingly, there's a lot of new machine-based learning. We're talking about neural networks, AI-assisted reads of MRI, which will potentially change the field or make things potentially better for everyone. There is definitely a lot of types of focal therapy out there. I'm going to talk about HIFU because it's a short presentation. But as you know, as I said earlier, I don't believe that HIFU is the best focal therapy. I think that they are just different variations. Some of them have their pros and cons to each of them. But in the US right now, the one that most people talk about is HIFU, because like I said, cryotherapy has gone a little bit out of, people have been less interested about it and asking about it. And then there's obviously laser and photodynamic therapy that are starting to become more interesting for patients. In terms of the data on focal therapy, we know that there's so many studies out there, right? But this is probably one study that is of, I think, high quality, that prospectively collected an actual study and trial. But there are many studies out there. But one of the criticism of focal therapy is that the definitions of how the study patients are recruited, how they're treated, and how they're followed vary significantly. But if we take this high quality study from England, where patients actually had focal therapy for prostate cancer, what they found was, you know, a little bit what is the hope of focal therapy, which is that patients preserve their functional outcomes, have minimal complications from the treatment, and depending on what definition you want to use here, 77% had absence of any cancer, and the vast majority of patients had no significant cancer. If you consider significant cancer, any Gleason 3+4 more than a certain length, as they used as part of this study. Interestingly, if you remember when this study came out, again, I love to draw the parallels with the adoption of robotic surgery. There were a lot of mutiny, literally. There was a lot of letters to the editors. There were articles, editorials written in other journals like European Urology talking about this article. And, you know, the Lancet still published this top left letter where they actually said this is unethical of a study. Some people questioned the fact that 9 men out of 39 still had some cancer in there. And why would this be considered a good treatment if you left cancer behind? But obviously our paradigms of what constitutes significant cancer has changed over time as well. There's other studies, and again, I am quoting a lot the UCL group because they have done a lot of good work in this field. But here's another study that they did that actually is quite recent, where they compared focal therapy to radical prostatectomy, a propensity score match cohort. As you can imagine, a retrospective study design, lots of limitations. But again, they wanted to show that, well, at least from an oncological standpoint, in a propensity score match fashion, the outcomes are at least reasonable with an 8-year type follow-up as part of this study. As I said earlier, there's a lot of problems, you know, in terms of assessing oncological efficacy, because it's pretty simple and straightforward to follow people after radical prostatectomy. But what do you do with patients who choose focal therapy? Do you follow them more using like traditional radiation oncology criteria, like the Phoenix criteria, or do you follow them more like an active surveillance, which is our approach? But if you're following them like active surveillance and repeating biopsies every once in a while, you are more likely to find cancer. And then are these real recurrences, or are these non-significant residual disease that would not necessarily have caused much harm in the long term? And I think that is definitely one of the biggest problems about trying to assess the quality of the evidence of focal therapy as it stands today, without, for example, clear, high quality level 1 randomized trials to inform the debate. So what other studies are out there? As I said earlier, we do perform focal therapy as part of a clinical trial that closed recently. And this is a trial that, from Insightec, which is an Israeli company with an office in the United States. And this is true focal HIFU. And what we mean by focal, it's not just focal as in targeting the lesion, but it's also under direct MRI guidance. So it's a complicated procedure, right? The patients have to be cycled constantly back and forth in the actual MRI, and the treatments are delivered under direct MRI guidance as part of the study. So this is an example of a study that is currently out there. The study is actually completed, and hopefully the paper will be published, in the near future. One thing I'll mention is, as you see here, the inclusion criteria included Gleason score 6 or 7. But in the later part of the study, the decision was made to restrict the patients of the study to Gleason 7. And the reason is that, again, the key opinion leaders, the participants in the trial, and I was one of the participants in the trial, felt that, to prove that this treatment works, it doesn't make much sense to treat the Gleason 6 that we would offer surveillance anyways. And that's why Gleason 7 was chosen as the inclusion criteria for this study. There are other studies that are hopefully going to help us inform the debate. And this is an example of one of them, where patients are either randomized to HIFU or to radical prostatectomy. And, obviously this kind of study in the long term can provide us valuable information about how viable is focal therapy. I mentioned the US situation and how, reimbursements matter. I don't fully understand the system in Brazil. But in the United States, this is an important driver of what we do, like it or not. We think that as doctors, we're supposed to be treating patients and doing what's best for them. But obviously, if you have a financial incentive, it can pervasively change your management. So HIFU before 2017, if you billed for it, it was not covered by any insurance. So basically, you could charge the patient whatever fee you decide, as long as somebody was willing to pay that fee. However, in 2017, Medicare is the insurance of everybody who's 65 and above in the United States, adopted a reimbursement code. So once you have a code, you can't bill the patient whatever you want. You have to bill the fee that is accepted by Medicare. As you can imagine, in these kinds of negotiations, there's a whole process, and they decided that the fee would be this number, which roughly amounts to, I would say, a little bit less than half of what they pay for a radical prostatectomy. So it's interesting to see that these codes now exist, and to see how this can affect how physicians practice. And that's the kind of study or research that I am interested in doing. Another insurance company, Cigna, also approved the use of HIFU officially. So again, if you have Cigna insurance, then you have to charge the fee that Cigna is willing to pay for it. But this is all, and it is only approved in the salvage setting, not as a primary treatment. One other thought, I know I have about 6 or 7 minutes left. This is an article, like an editorial that Jim Hu, who's at Cornell, wrote in JAMA, and I thought it was interesting, is that a lot of people say, hey, focal therapy is less morbid, costs less, this is potentially a great treatment for our patients. But you also have to consider that if you treat somebody with HIFU and the patient has a recurrence and you treat him again, and then ultimately he ends up needing a radical treatment, well, the costs are eventually going to be more compared to the person who just went straight to definitive therapy in the beginning. And again, this is all hypothetical, but it is definitely worth consideration if you're trying to think about cost to the system. It may be cheaper immediate costs with less side effects, better quality of life, but you have to assess over the long run, over 5-10 years, which is the best approach. In the last few minutes, I thought I would present a case, but actually, I would say one of the cases that was presented is a little bit similar, but I think it'd be interesting for you to see this. So this is a 70-year-old male who was on active surveillance for Gleason 6. His PSA, I think, started around 6 and was rising now, was at 9. And then he came to see us with this prostate MRI, which shows a left peripheral zone anterior lesion on the prostate MRI that was done in January 2018. So we took him to a fusion biopsy. And as I said earlier, prostate cancer is rarely in one specific area. In this case, what we found clearly is that you had some specks of Gleason 6 prostate cancer, not too significant disease, but clearly one area in this targeted area where it was Gleason 7. So this is what, at least in our book, a good candidate for focal therapy, somebody who has some Gleason 6 here and there, but ultimately has one lesion that lights up on the MRI targeted where the significant disease is present. So this patient had focal HIFU, so HIFU of the area of concern in November of 2018. And this is the immediate films that were taken right after that. And you can see the area of tissue destruction from the HIFU that corresponds to what I showed you earlier on the MRI, and a little bit more to make sure that we get more tissue. And you can also see that we really tried to preserve the urethra and not damage it and cause any additional irritative symptoms as a result. His PSA did go down, and if you look at this MRI, you can tell that there's significant area of tissue necrosis on the subsequent MRI that was done, and his PSA, like I said, went down to 2.62 with a targeted treatment, which I guess is relatively good. We took him back. As I said, we are following these patients stringently like active surveillance patients. So we took him back to do prostate biopsy, and because like I said, the MRI didn't show any focal lesions. And interestingly, as you can tell here, there was still some Gleason pattern 4 present, so probably at least Gleason 7 that was still present, and mostly in the areas of on the left side. So, as you can imagine, this is a patient who really, really was seeking focal therapy, was not really interested in definitive therapy. We had this long conversation, but he ultimately asked us to proceed to repeat focal therapy. And the idea here is that this is a transrectal biopsy. And if you go back to the previous films and you see the targeted area of ablation, the assumption is that the anterior zone was treated correctly and that my biopsies being transrectal, the random samples probably caught a lot of the peripheral zone in the back. So the idea here, when we went back to do focal HIFU, was to treat the posterior peripheral zone, because we presumed that my biopsies that caught some cancer and some Gleason 7 pattern was probably from the posterior peripheral zone, and that is what you can see. This is the immediate films from the HIFU treatment of August 2019. So following that, the PSA went down again. Now it's 1.19. We did an MRI in January 2020. There was a pyrette 3 lesions, but at least the ablation zone seemed pretty clear. We took him back for a biopsy. And now this time, we found cancer present only as perineural invasion, involving less than 5% of one of 2 cores. Everything else was negative. So, we did like 20 biopsies, and this is the only thing that came back. By the way, as you can imagine, along the whole case here, every single time I think I presented the case at Tumor Board, we rediscussed this. And this patient, like I said, not interested in definitive therapy. We decided to wait, but we told him, look, with this finding, we're probably going to do a biopsy in the near future again, just to reassess the situation. So we do another MRI now in December. His PSA is still pretty good, 0.93. There's now a lesion in the left peripheral zone right next to the treatment area. It's a little concerning. We take him back for a biopsy, and this time around we find Gleason 4+3. I talk to the patient, say this is not compatible with surveillance. You either have to do radiation or surgery. And now this time around, after going through all this, he agrees to salvage radical prostatectomy. And lo and behold, I did his surgery recently. And as you can tell, the disease was Gleason 3+4, contained negative margins, but positive lymph node. One of the lymph nodes was positive with extranodal extension as well. And this is where this case ends. So again, it's an interesting case. It is probably the kind of case we present at Tumor Board. They're not all like this. but it's definitely worthy of consideration when we try to understand the biology of this disease. So I think I'm going to end there. I don't know if we have time for one question or not, or we're running a little late. But like I said, that's my thoughts a little bit on focal therapy, and happy to take questions, and thank you for having me.
Thank you so much. Great. Yes, we have time for one or two questions. Anyone wants to make a question? So our system is pretty similar to yours. So yes, we have the same process, and for time period we don't have a code or something, and then the procedure begins to be covered or turns to be covered, and then that's pretty similar to your system. Any questions? I think the
Yes, I have a question.
I have a question too.
Yeah, the last two questions. Professor Carlos first, and then Matheus. Professor
Coop, what's your results about your experiences with HIFU? How percentage of good results of HIFU?
Functional or oncological?
Oncological.
Okay.
Both.
I think oncological. So our biggest problem with our oncological data of HIFU is just that most of it is short term, right? You can quote the studies from the Emberton group that are long term that seem to be doing pretty well. You saw the UCL data, but our data in short term, it looks fine. It looks not as good as radical prostatectomy, but not bad. Definitely better than doing nothing. Significantly better. Maybe just a little bit under radical prostatectomy. But then the problem is the bias, right? We select our patients extremely carefully, right? So can you really compare all these Gleason 7s that we treat with surgery to the carefully selected low volume Gleason 7 on an MRI that shows only cancer in one area? So that's one concern. But we have, I can tell you 2 or 3 cases like the one I just presented that are extremely concerning, and you wonder what would have happened if this person had chosen surgery back in 2018. So like I said, my answer to the question is that it's hard to make those comparisons, and because of the heterogeneity of the data and how it's collected and how we assess recurrence in these people, right?
Well, Matheus, and then
Right. Dr. QUOC, thank you for your presentation. I have a question that concerns the second case that I've presented. Have you performed any radical prostatectomy for those patients that failed the focal therapy? And which approach would you decide to use? And is there another technical difficulty for doing that, something like that?
So that's an interesting question. Actually, it was part of my presentation, but then I just skipped it because it was towards the end. The data from UCL is that the outcomes are quite favorable. Hey, my daughter's making a guest appearance in this presentation, but the data is pretty favorable. It's surprising how they reported that there's not necessarily poor functional outcomes, and obviously not the sexual side, but at least the urinary side, in patients who undergo salvage surgery after focal HIFU, compared to, let's say, radiation, where they can have pretty serious, like incontinence and strictures in way, and I have had my share of, poor outcomes in those situations. In my experience of doing a couple of a salvage prostatectomy after HIFU, they do pretty well from a continence standpoint, and I'm pleasantly surprised. At least it makes me feel better about offering HIFU, knowing that I can do this and not render these men, invariably incontinent or something.
So Marcelo, last question, please, Marcelo.
Okay, thank you, Dr. QUOC. Is there a place for PET-CT, PSNI in the follow-up of these patients? In the last case, possibly PSNI will identify lymph nodes in pelvic region. What is your experience?
So the answer is absolutely yes. And, I am somebody who, so first of all, we don't have access to PSMA yet in the US. I know it's insane because I know my friends, you guys in Brazil, you have access to that, but we don't have readily available access. Like, for example, for us to get a PSMA, they have to enroll on trials. And the trials obviously have inclusion criteria, and this patient would not meet any of them. We have access to Axemen PET. And Axemen PET, as you know, has its caveats, but it's definitely something that I do order. But in this patient, I have to admit, I didn't think of it, and neither did the tumor board, because you saw his PSA, it's like 0.93, 1 point something. So for me, when I had the conversation with him, it felt more like, I think that this is not working. I'm going to do a prostatectomy and you should be fine afterwards. I never expected that we were going to find a positive lymph nodes. But at the same time, I don't know what's going to happen with this person. Maybe he's going to be like your case that you presented and not develop, any, recurrence or, detectable PSA in the future. We'll see, right?
Okay, thank you.
So, QUOC, thank you so much for your time. Wonderful case discussion with your thoughts, and also wonderful presentation. So thank you so much. We'll finish. I'll direct the control for Cássio, but you have the words now. Thank you so much.
Hey, of course. Thanks for having me again, and see you all soon. Okay, hopefully in person.
Thank you.
Thank you.
Bye-bye.
Bye.
Okay. Thank you very much about our expertise and to share your time with us this morning. And I'd like to have you another time with us for another presentation, Professor. Okay? And bye-bye. Eu gostaria de terminar a reunião, então, uma ótima reunião. Agradeço aí ao empenho da organização do professor Leonardo e voltaremos aí para a semana que vem para mais uma da disciplina de Urologia. Bom dia a todos, bom trabalho.